All right, let's do this then, shall we? Good evening, ladies and gentlemen. Welcome to ProMed's training on the different roles and remits of pre-hospital care providers. My name's Matt. I'm the Managing Director of ProMed. If I could just ask you all to introduce yourself in the chat box, say hello, let me know where you're joining us from this evening, please. Okay, hello everybody who's just typing in there for us. Welcome. Sorry that we're a bit late in letting you in this evening. We're just making a few finishing touches. Good to see our regular faces and a couple of new ones are back there. As you know, we're providing these webinars free of charge, but we do have the usual suite of FREC and the add-on courses available. If you visit our website, www.promed999.co.uk/training for full details. Our next FREC 3 starts on the 24th of October over 3 weekends, and that's £390. Our next FREC 4 starts on the 3rd of October, £475, both running from our training base in Aylesbury. And we have the level 4 award in immediate life support for £150, or the safe administration of life-saving medications course, which is £200. Please visit the website or get in touch if you'd like to book onto any of them. Our admin team has just posted this message on the chat, so if you do need to contact us, please feel free to do so privately. We would like to see everybody being treated with dignity, respect and courtesy and not be discriminated against. Tonight we're going to be looking at the different roles and remits of pre-hospital care providers. Now they can be broken down into 8 different groups. So non-certified first aiders, certified first aiders, first responders, non-registered healthcare professionals who care for patients as a secondary role, non-registered healthcare professionals who care for patients in a primary role, ambulance technicians, registered pre-hospital healthcare professionals, and advanced registered pre-hospital healthcare professionals. Those titles are either directly taken from the Faculty of Pre-Hospital Care's skills matrix, or they are a slight variation on what is there, which makes it a little bit easier for us to understand. So if we start at the bottom and work our way up, a non-certified first aider has the skills to wear the correct PPE, assess a scene for danger, and assess the safety of a casualty. They can communicate with the emergency services by 999. They have an awareness of triage, i.e. which casualty they need to go to first. They have an awareness of the high risk injury mechanisms and have an awareness of simple consent. So are you okay with me doing this? They include people who have done a BLS with DFib course or some in-house training courses. So these people are literally the people who can perform basic life support, use a DFib, and ring 999. That's pretty much the limitations of their training. So theoretically, in a few years' time, everybody leaving school will be meeting this description because first aid, basic life support is now on the national curriculum for all school children. So once that's taken effect, which is 2021, is compulsory. So by 2022, any child leaving school should be able to wear PPE, check a scene for safety, check a casualty for safety, ring 999, understand they need to treat the person who doesn't look like they're breathing before the one who is shouting at them, understand they need to ask before they do anything if the patient's conscious, and jump up and down on the chest. Beyond that, we have certified first aiders. So certified first aiders can do all of the above. They should also have been shown how to do manual inline stabilization of C-spine injuries. They should be able to recognize hypo or hyperthermia and thermal injuries such as burns, scalds, chemical burns, electrical burns, and so on. They should be able to handle casualties. Now, we're not talking the use of any equipment. We are just talking handling casualties in terms of lowering them to the ground, putting them in the recovery position, assisting them to stand up, assisting them to sit down, walking with them, just the basics where you don't require any equipment. And they should be able to recognize the common medical emergencies, so seizures, life-threatening asthma, diabetic emergency. Again, nothing in too much detail, not necessarily being able to treat them. They need to be able to recognize them and recognize that they need to call for assistance. So this is people who would have an emergency first aid at work or a first aid at work certificate. Quite common in workplaces. Thousands or tens of thousands of these across the UK. And their role is basically to do what they can to follow what is in the first aid manual and to provide support for the casualty whilst awaiting a higher grade of qualification to assist. Things start to get interesting at the first responder level, which is skill set C on the FPHC skills matrix. You'll have to excuse me if I mute and cough. I have a bit of a cold this evening. First responders should be capable of doing a dynamic risk assessment. So they should be able to walk up to a scene, check it's safe, but they should also be continually reassessing that. They should know that things can change. They should know that there are different kinds of threats, not just the physical ones, but there could be emotional threats. There could be threats from people as well as threats from physical things. And they need to know that they need to continually reassess that, not just for themselves, but for others they're working with, for their casualty, and also they should be risk assessing any risks to the bystanders. A first responder should have an awareness of the different capabilities of different types of emergency services personnel. So they should know that HART are the ambulance special rescue people. They should know that you've got the police firearms, police helicopters. They should know about the mass casualty equipment vehicles. They should know about fire and fire technical. They should know of mountain rescue, of Coast Guard, the RNLI, and they should know how they differ and what each of those different emergency services can do. So when they're communicating with the emergency services, they can be a bit more specific on what's actually required and why. They can manage catastrophic junctional bleeds. They can manage simple airway adjuncts and have an awareness of C-spine management. So by simple airway adjuncts, we are talking nothing more than an oropharyngeal or a nasopharyngeal, so your OP and your MP airways. Things that you can just quickly measure by looking at the nostril or by sizing at the side of the face and having the consideration for C-spine. So can you do a trauma jaw thrust? They should be able to do that. They should also be able to do a little bit of C-spine management in terms of they should have been trained how to participate in a log roll. Not necessarily be the lead, but they should certainly know why we need to listen to the person at the head, why we need to all roll together, those kind of things. First responders should be able to assess breathing and circulation, so they should be able to do a cap refill. They should be able to do pulse oximetry. They should be able to assess the rate, the rhythm, and the depth of a person breathing. They should be able to take a radial pulse, and they should be able to determine whether that's regular, regularly irregular, 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 or absent. They should also know about mental health, so they should know of different mental health conditions, anything long term in terms of an effect on somebody's day-to-day life. They should also know in the short term how that might affect their capacity, and they should also know capacity in general in terms of anything that may impair a person and their ability to give consent. So this includes people who've done stuff like FAW with DFib, with gases, with something else. It includes your community first responders who have followed an in-trust or in-house kind of training pathway, as long as it's covered everything that's mentioned there and all of the above. So it doesn't matter what level we're talking about, everybody can do basic life support with DFib. Anything from first responder and below should not be used on an event. If we read the Purple Guide is very clear that first responders, first aiders certainly should not be used, and it has clearly defined a first responder. Now, the Purple Guide does have a slight variance from the FPHC here. FPHC skill set C doesn't match the Purple Guide's requirements. So we move now on to the non-registered healthcare professionals secondary. So those who have a secondary responsibility for treating casualties and treating patients effectively. Now, this is the first level that you can use on an event, or certainly the first level that can be counted in the numbers for being an event first aid or an event medic or part of the event medical team. And that's because of the additional skills that come with it. That's because of the additional training they'll have had, perhaps the experience that came with that qualification, and the CPD requirements that get tagged on at this level. So these guys could be FREC 3. They could be enhanced community first responders. They could be police officers who perform specialist roles. They could be fire service IECs. They could be United Kingdom search and rescue trained. And the skills that they'll have in addition to all of the above will be radio communications. So they know how to communicate by radio. They know the importance of speaking clearly, using plain English, how to use the push to talk key, how to change channel, how to turn the volume up. They should know about call signs. They should know the importance to ask, who do they need to speak to, and how they identify themselves when they're accepting a radio. They'll also be trained in triage civ, so don't need to remember it, but they should certainly know what triage civ is. They should know what the action card looks like, and they should have practiced using that triage civ in a controlled environment. They should be aware of forensics, so they should be aware that a patient can themselves be a crime scene. They should be aware that they should do the minimum amount necessary, the minimum amount of casualty handling, the minimum amount of investigation where they believe that a casualty is a victim of crime. They should be able to talk to a casualty about forensics and explain why they are doing things or why they are going to suggest that somebody talks to the police or an appropriate service. They will be able to use combat application tourniquets. They will be able to use hemostatic agents. They'll be able to pack any large kind of wounds and cavities or any kind of profuse bleeding. They should also be able to use suction. So most courses teach manual suction, but they should also be able to use a powered suction unit. They should be able to apply a chest seal. So I don't mean a manual kind of plastic bag and a bit of brown tape on 3 sides job. I mean things like your Ashley and your Russell chest seals. They should have used those for real in training. And it is only at this level that bag valve masks actually come into the scope. So below this level, the FPHC says the minimum requirement is that you can do basic life support with a mask or with a face shield. When you get to skills descriptor D, you are now expected to be able to use a bag valve mask as a 2-person technique. The 2-person technique is where one person holds and maintains the seal of the mask on the face, and the second person operates the bag itself. We now step up to our FREC 4s, and we're also looking here at UK search and rescue, certain military personnel, so CMT2s, specialist certified police officers, so typically firearms, police medics, and specialist certified firefighters, so again, your firefighter medics. We refer to these from the Purple Guide as emergency medical technicians. These people can also nebulize, not necessarily the drugs, but they can set up a nebulizer. They can give saline water through that. They can assess pupils for being equal and reactive to light, and they have a limited scope in terms of pediatrics. They should know the normal physiological parameters for children. They should be able to assess a child using the pediatric assessment triangle. And they should have a basic understanding of childhood conditions. So in terms of ambulance world, just to go back, we've got community first responders are first responders at skill grade C. We've got enhanced community first responders as non-registered healthcare professionals caring for patients in a secondary role as skill descriptor D. And at skill descriptor E, non-registered healthcare professionals caring for patients in the primary role. In ambulance world, we call these emergency care assistants. Now, this does vary from trust to trust, and it is quite hard to put some differentiation on, because for some trusts, an emergency care assistant must also have a recognised blue light driving qualification, such as the Certified Emergency Response Ambulance Driving from Future Quals. However, other trusts allow people with an appropriate qualification that meets skill descriptor E to be an emergency care assistant. If you've heard of the term ambulance care assistant, an ambulance care assistant typically falls at this level below, which is your non-registered healthcare professionals caring for patients in a secondary role. However, you can also get people at this level who would be called an emergency care support worker if they have a blue light driving qualification. So the ambulance world, the trust NHS ambulance world is now starting to muddy the waters compared to how pure almost the FPHC is and how aligned the Purple Guide is to the FPHC. We then move on to ambulance technicians. So ambulance technicians are ambulance technicians are ambulance technicians the world over, to be fair. It's one of the few non-protected titles that people don't seem to be messing around with. So an ambulance technician is a non-registered healthcare professional. They're sitting at skill level F, ABCD F on the FPHC skills matrix. They are non-registered healthcare professionals, so they do not need to be registered with any particular body. And these are your level 5 FRECs. These are your associate ambulance practitioners. These are the IHC, the ambulance aid qualifications. These are CMT1s. The Red Cross ran a pathway to get to this level. These are people who have done a qualification which has a mandatory mentored clinical practice placement. So you should not be able to get up to this stage on FPHC skill descriptor F without having done some mentored clinical practice. Now, typically for most of those qualifications, that'll be a minimum of 750 hours. Excuse me again there. So at this level, the mandatory skills would be supraglottic airway devices, which are your iGels and your LMAs, your laryngeal mask airways. The monitoring interpretation of end-tidal CO2 for ventilation, blood pressure, the use of traction, wound dressings, Glasgow Coma score, blood measures. Should also be able to deal with pregnancy and neonatal. They should have an understanding of section 136 for mental health detentions. They should be able to recognise life extent. And one of the key components here is that they can definitively treat and discharge. Now, for those of you who are following the FREC pathway, what you'll notice is that the FREC pathway covers at level 4 supraglottic airway devices, end-tidal CO2, blood pressure, traction, wound dressings, Glasgow Coma score, blood measures, pregnancy, neonatal care, mental health, section 135 and 136, and recognising of life extinct. So it is almost at that level. The difference is there are just a few more medical conditions that you learn about at level 5, but you can also definitively treat and discharge. So the ambulance technician level comes with a rather well-defined scope of practice. However, that scope of practice does vary from trust to trust. It does vary from company to company. In terms of the medications that they allow their ambulance technicians to use. If you've done your Safe Administration of Life-Saving Medications add-on because you work for a CQC company, then you may be working very close to this level because you can treat a lot of the conditions now. You can definitively treat them. However, you probably would not be allowed the discharge unless you had done the mentored clinical practice. If not, then depending on who you're working for, it may be a case of you need to make a phone call and speak to a registered clinician to discharge, or it may be that you need to wait for a face-to-face assessment from a registered HCP. But the ambulance technician is higher up than an emergency medical technician, if we're going to use the truest sense of the words from the Purple Guide and from sort of days gone by, if you will. Things get a bit muddied now because we do have emergency medical technicians in the NHS who are actually ambulance technicians, but they are wearing and are employed as emergency medical technicians, although they have and are qualified to and use a higher skill set. So if you see an emergency medical technician, it is worth playing the safe card and assuming that this is their level of practice. However, if they're working within the NHS, it is worth asking what their role actually is, because it may be that they are an ambulance technician and are just working to a slightly, they have a slightly different role marking. And the confusion here is for those who've only ever worked in trust, for those who don't step outside the event in the private sector very often. Because they are so used to seeing emergency medical technicians markings on people who are actually ambulance technicians, they assume that emergency medical technicians are qualified as ambulance technicians when that's not the case. And they then take offence at people calling themselves emergency medical technicians when they're not ambulance technicians. But actually, if you read the likes of the Purple Guide, they're not doing anything wrong. They're actually following cross-industry best practice, and it is the NHS ambulance trusts that are using role titles of a lower kind of role than is stated. We can now move on. We've got registered pre-hospital healthcare professionals. So you've got your HCPC registered paramedics, your GMC registered doctors, where their main role would be pre-hospital or emergency department or anaesthetics perhaps, particularly where they have done pre-hospital training or a member of a scheme such as Basics that provides them with their pre-hospital CPD. And you also got your NMC registered nurses and midwives, because what we've got to remember is a midwife, not all of them are based in the hospitals. We've got a lot of community midwives, and they are ultimately pre-hospital healthcare professionals. They are outside of the hospital. They are providing support, and indeed, if in the ambulance world, how often are we told, if you're unsure about a pregnancy or if it's a pregnancy and it's about to give birth, call a midwife. And that midwife will be working as a pre-hospital healthcare professional alongside a paramedic, alongside any other pre-hospital care staff in exactly the same role. They are providing pre-hospital healthcare to a patient. But generally speaking, for most, they will have done some kind of pre-hospital CPD, or they may have done some sort of formalized training if they're going to be operating in the pre-hospital arena. And then finally, you've got your advanced registered pre-hospital healthcare professionals. Now, the difference between our previous role, which is the clearly defined scopes of practice, the titles are all protected in law, and being termed advanced, is that you've got additional skills. So to be an advanced registered pre-hospital healthcare professional and recognised as that by the FPHC, and you can get certificates. There are training courses and CPD opportunities provided by the Faculty of Pre-Hospital Care. You must be able to demonstrate competence in triage sort, incident command and casualty dispersal. You also need to be competent on the procedures of surgical airway, finger thoracostomy, chest drain, thoracostomy. You need to be able to deal with a massive hemothorax, use blood products, use a mechanical ventilator, do wound closure, deal with pregnancy complications, and manage dislocations. Beyond that, there are some advanced registered pre-hospital healthcare professionals who can also do rapid sequence induction, thoracotomy, and emergency cesarean section. Not all of them will have that, but certainly if they're flying in on a helicopter, well, they're the things that they tend to go to by default. And that's it on tonight's webinar. It is a bit of a short one. That is deliberate because I've got a bit of a cold and don't really want to be talking for a full hour. So if anybody does have any questions, I'll happily take questions. Please do engage in a little bit of discussion. I know there's not too many of us tonight. If you would like CPD certificates, please email webinars@promed999.co.uk with your full name. We'll just verify you're on here and that you've left us a review on one of our lovely review sites, and we will get round to sending these certificates out. Sorry, there's a little bit of a backlog, but we are going to try and get that cleared this weekend. We did provide the webinar free of charge, so please do leave us one review. We are on Trustpilot, we're on Yelp, we're on Google, and we're on Facebook. So please leave us a review if you want your certificate. And if you have any questions, please type them in the chat box or raise your hand and unmute yourself. So here we go. So the step up from FREC 4 to FREC 5, you'd have thought it'd be a big upgrade, but doesn't seem that from the slides. So realistically, Nathan, if you've done your FREC 4 and then you've gone and done your safe administration of life-saving medications, and then you want to go and do FREC 5, there's not a massive amount in terms of new content. So you revisit quite a lot of your trauma. You revisit and expand on your childhood conditions. You'll learn a lot more about treating the childhood conditions. There is a lot on ECG interpretation. Although within the FPHC itself, the FPHC doesn't say that 12 lead is until registered healthcare professional level. Although your FREC 5 does cover ECG and certain levels of interpretation. You obviously revisit your immediate life support, same as you will do on any training course. You will always do life support. And then beyond that, it's the 750 mentored clinical practice hours. So of your 3 classroom weeks, one is more or less a full repeat of FREC 4. One is mostly ECGs. And then one is treating your childhood and medical conditions using the new scope of practice that you've got. So when I say redoing your FREC 4, I do also include your SOM, your ILS. So it's basically kind of 7 or 8, 9, 6, 5, 6, 7. It's basically about 8 days plus all those books you did consolidated down at the 5 in terms of the level of depth you're going to. It's more refreshing and just expanding slightly. Let's have a little look. Alexander, there seems to be an improvement in streamlining qualifications, but how do people transfer qualifications and experience as in non-pre-hospital healthcare or from volunteer organisations such as British Red Cross or St John Ambulance into private hospital sector pre-hospital care? So if you're from within hospital, you will be operating within the scope of practice, and one would assume that you've obviously been trained. So if you can evidence that training, then you should be able to get recognised prior learning. So you'll still have to do the assessment. You shouldn't be able to get any qualification without having been assessed. But if you can demonstrate you've done recent training, so recent usually meaning within the last 12 months or the last 3 years, depending on what exactly it is you're evidencing, you should be able to have that prior learning recognised by an awarding body. And then your training centre would go about arranging an assessment process for you so that you can demonstrate you're still competent. And then you would then be able to obtain that qualification almost directly, if you will. The issue with volunteer organisations such as British Red Cross and St John Ambulance tends to be their internalisation of qualifications. So the British Red Cross were quite good when the IHCD was around. So with Pearson Edexcel, they had a programme whereby their ambulance attendants were able to get IHCD ambulance aid. But at the same time, the British Red Cross were offering that, St John Ambulance were moving away from providing externally verifiable first aid certificates and putting their volunteers through an internal pathway with certificates that were only valid internally, and they made it very clear that those certificates were only to be used internally. So because those certificates are only able to be used internally, because the syllabus that went along with those qualifications was an internal St John document and it was very clearly marked that it could not ever be used externally, then no awarding body could then map the prior learning because officially they didn't know what the prior learning was. You can't map prior learning if you don't have a syllabus. If you don't know what the learning was, you can't map your assessment outcomes to it. And that created a little bit of difficulty, it created a little bit of friction. But ultimately, the person who's the worst off tends to be the St John volunteer who also wants to work privately. There is no easy way around that one other than to go and do something like FREC or an FBOSE or one of the other qualifications, because no awarding organisation is able to take the St John syllabus and map their assessment objectives against it because they're not allowed to have the syllabus, unfortunately. Neil, I have seen your email about Trustpilot. I have yet to reply to Trustpilot about that, but thank you very much. The grades on the FPHC site, yes, that's a good one. That was just sent to me privately. If you just give me a second, I will pull the skills matrix. I have both of those links in my favorites. If you just bear with me, let's get that. FPHC skills framework. So your skill titles. So the first one is a skill title, which I'm just going to give you. Just bear with me there. Skill titles to everyone is there, and the competency matrix. I would strongly recommend that you download both of these documents and save them. They are very, very useful. So this competency matrix is the minimum that the Faculty of Pre-Hospital Care expects that person operating at that grade to be able to do. You may have competencies of a higher grade and you may be able to use them, but the minimum required to call yourself the skill title is what is on that competency matrix. Let's go the other way. Just made a massive breakthrough this month. St John have accepted FREC 4 as an advanced first aider. They won't entertain HC or EMT as an APL from FREC 4. That's, yeah, I really don't know what to say to that, Nathan, because the FREC 4 syllabus and specification and the acceptance by the FPHC as being skill descriptor E is all publicly available. FREC 4 is my understanding of St John's qualifications is that FREC 4 is the same as, if not exceeding, emergency transport attendant. Obviously, the blue light is a separate message there, but it is a shame that organisations that aren't accepting qualifications that are regulated by Ofqual. That's all I can say to that, really. It is definitely on the regulated qualifications framework, as is AAP, as is FBOSE. If they're on the RQF, there's no reason why an organisation shouldn't be accepting them. Alexander, yes, combat medical technician and MOD qualifications are likewise recognised. Yes, so There are pathways. QualSafe Awards have some pathways that are mapped. They've already mapped their qualifications against the military sort of healthcare levels, if you will, or CMT levels. To get a QualSafe qualification off the back of that, you do have to prove you were still using those skills recently. So you saw recent discharge in role, or if you're still serving as a reserve, proof that you're still doing that, and then you would just have to do an assessment with a training centre, and they'll allow that. East CFRs accepting FREC 3 and 4. I would really hope that East are accepting FREC 3 and 4, given that East are allowing private crews to use the FREC pathway against their roles. They've got a defined scope of practice. They say what roles fit what scope. So yes, I would hope their CFRs can. You can be a CFR with FREC 3 and FREC 4, given as their FREC 4s are emergency care assistants. East are, I would say, one of the more progressive trusts in that regard. EMAS are quite good. Other trusts, perhaps less so. And yes, I mean, to be fair, all organisations have safeguarding training. I'm a school teacher. I've just had to do, in the last 3 months, I've had to do 2 full days worth of safeguarding training. Despite the fact that in the last 12 months, I already had about 36 hours of safeguarding CPD from my medical and teaching backgrounds. It's just the way it is. I started at a new school, so therefore I had to do their safeguarding training. It's no different with ProMed. If I don't see safeguarding that I'm particularly familiar with, then I would expect somebody to do my recommended course. Neil, off the top of my head, yes, LAS have their own CFRs, but they tend to effectively outsource quite a lot of it through one of the voluntary or a smaller group rather than direct management off the top of my head. Can you just explain what you mean a bit about that, Neil? I don't quite get what you mean with the LASERs or FREC 4, but you have to do their course. CFR will accept FREC 4 for existing members. I don't really know what you mean by that at all. Thank you, Alex. Yes, I hope I get better soon as well. Yes, thank you for your prescription. I agree. I will go and get my TTA shortly. So emergency responders are trained to FREC 4, but you must still do their FREC 4 course. So so Neil, am I right in thinking if you already have FREC 4 and you come to them to be an emergency responder, are they expecting you to then basically redo your FREC 4 but through them? Wow. Sometimes there are just no words for some organizations. There's a reason I set up my own medical company. That's pretty much all I can say. I got fed up of working for other people and some of the crazy rules that people do. For those of you who have done stuff with ProMed, you'll find that as long as you have an RQF qualification where the awarding body is in existence and I can verify it, as long as you have a DBS on the update service, or if not, we will arrange one. If you're not trained, we will arrange training for you. We will literally we make it as easy as possible for people to come and work for us. If you have the qualifications, you do your CPD, you can be vetted and screened easily, or if we need to make arrangements to facilitate that, then come and work for ProMed. I try to be as simple and as easy as I can in that regard, but at the same time, I keep people safe. And I, as you saw from the previous webinar, I do take safer recruitment very seriously. But I like people who want to work, and I like to give them work. Yeah, so if you become a basic CFR, then you go and do FREC yourself, you can upgrade to enhanced CFR. But if you've already got FREC and you apply to join them, you have to do their basic CFR course. Oh, yeah, my head's hurting too much, Neil. Yeah, my head hurts too much, Neil. You just don't know what to say sometimes. Okay, does anybody else have any further questions, or can I go and get my hot toddy? It's not a continuous cough, Neil. I can still taste everything normally. I can still smell everything normally, and despite taking my temperature, it's well below. It's still sitting in the 36s. Self-isolation does sound like a good idea. I have tried and tried to find some different ways to be able to get away with self-isolating, but it hasn't worked. Oh, okay. So I look forward to getting your emails for your CPD certificates and reading your reviews later. Thank you very much for staying and persevering with what I can only imagine is my really horrible voice when I've got a bunged up nose like this. Um, and I look forward to seeing you back next week. Thank you very much, everybody.